guys, welcome to my kitchen. My name is Rebecca Packard, and for this case assignment, I will be presenting on case number 6, in the casebook of Abnormal Psychology regarding Body Dysmorphic Disorder, or BDD. In this case review, I will first discuss what the disorder is, then I will describe notable and crucial points of the subject's case, detailing history and symptoms, and I will describe the book's use of treatment. And later I'll delve into the critical thinking questions provided in the specific case. So, body dysmorphic disorder manifests as, according to the Casebook of Abnormal Psychology, as a preoccupation with one or more perceived defects in appearance that are not observable nor appear slight to others. At some point during the course of the disorder, the individual has performed repetitive behaviors such as picking at the skin or mirror checking constantly, and the preoccupation causes significantly clinical distress and impairment, whether physically, socially, and overall functionally. The case's subject is a woman named Tina Mobley. She is 33 years old and in an established career. However, she sought help at an outpatient facility due to her extreme consciousness of the state of her skin. The chapter continues to describe her clinical history and whatever state resembles the condition of BDD. Firstly, her family history. The chapter describes an aspect of influence and learned behavior from her father and just her immediate family. Particularly, her sister was diagnosed with bulimia nervosa, which is a disorder that is related to BDD, and her father worried extensively about his weight. So due to this home environment with so much emphasis on bodily image, Tina is described to have worried extensively about her physical appearance as a child, from the formative age of even 15. What fascinated me about Tina's case is that initially she was worried and focused on the broader spectrum of her physical appearance, but as time went on, she began to worry more about smaller intricacies of herself. And with these anxieties, she was led to a constant need for reassurance from her friends and family. The casebook goes on to mention that these symptoms significantly impaired Tina's functionality in social relationships, whether that be with friends, family, or even romantically. After the casebook describes Tina's struggles and gives a picture of the intensity of her case, it delves into the treatment for Tina. Her therapist had her record every single time she would pick out her skin and increased her awareness and Tina's increase for her awareness lessened her behavior. She also underwent cognitive behavioral therapy and exposure therapy, giving her resources of education so that Tina would understand the deprecation of her behavior towards her body. Additionally, Tina's therapist had her work on decreasing her negative coping behaviors when she was triggered and replacing them with beneficial coping techniques and habits instead. At the end of the case, Tina is reported to have significantly recovered. The casebook states that while Tina still notices that her BDD thoughts are there, she actually knows how to manage them after all the extensive treatment she underwent. So in this chapter, the casebook gave us some 4 different critical thinking questions. So I'll answer all of them here. Number 1 says, in this chapter, the differential diagnosis of BDD was discussed. Given the overlapping features BDD has with other disorders, do you think it is best classified as an obsessive-compulsive disorder, somatoform, anxiety, psychotic, or impulse control disorder, and why? In terms of anxiety-related disorders, do you think BDD is more similar to OCD or social anxiety disorder? I often wonder how much this can be different when related to specific cases, and where maybe the individual might have different intentions to why they have behaviors of BDD. For Tina, and generally as far as I can tell from reading her case, I can see how her anxious state relates most to OCD, with just the constant need for perfection, just towards her own body. Her behavior is enveloped in a deep impulsivity to pick at her skin, and it seemed to come from a place for the need for perfection. Secondly, while I would generally classify BDD with OCD over social anxiety, I wonder if Tina's case is unique in this respect. Often social anxieties in her life were a trigger to her behavior, so I wonder if her skin picking was as a coping mechanism. Number 2, the book asks, current behavioral treatments of BDD have several components, including self-monitoring, cognitive restructuring, ERP, behavioral experiments to evaluate fear predictions, habit reversal training, and mirror retraining. Which of these treatment components do you feel like is most important, and why? I answered that out of all the varying treatments, I think ERP, the exposure therapy, is the most effective. According to the textbook Psychopathology, the course textbook even, an integrative approach to mental disorders, the author Dr. David Barlow writes that exposure and response prevention, which is a type of cognitive behavioral therapy that is effective with OCD, has also been successful with BDD. Oopsies, wrote that quote down wrong, guys, sorry. Dr. Barlow goes on to say that 82% of patients with this form of treatment responded well. Number 3 of the questions, it says, thus far, there is no strong evidence to indicate that there are marked sex differences in the prevalence of the clinical presentation of BDD. What might that be so? On what aspects of clinical... guys, I can't read. On what aspects of clinical presentation of BDD, for example, areas of appearance concern, types of behaviors in play to reduce appearance and distress, associated features such as like suicidality or aggression, do you think men and women most differ, and why? Based on the culture and surrounding social norms, I think it makes sense that there isn't a clear statistical difference between men and women in this disorder. Men have higher expectations of other bodily appearances that women experience differently, but to a comparable degree. For example, men differ in their muscle size, whereas women might differ in their weight. And so to combat that, men might work out more, women might go on diets more. This shows a correlation in the way the BDD manifests through differing social expectations. To the second question, where it talks about associated features of suicidality and aggression, it kind of makes me think of how men, this is a later chapter, but men manifest in psychological symptoms of narcissism, while women, their psychological symptoms manifest in histrionic disorder, which is more towards the self, but just in different ways. So I think that was very interesting. For the final question, number 4, as was noted in this chapter, BDD often goes diagnosed by health professionals because the patients do not report their symptoms due to embarrassment, shame, and failure to recognize that their problem is due to a mental illness. Considering these potential barriers, what do you think would be the best way to screen for identity BDD cases in healthcare or other settings? Types of questions to ask and warning signs to look for. I could not read his name. I honestly don't know where he's from, but he's a doctor who wrote a scholarly work called Body Dysmorphic Disorder, a critical appraisal of diagnostic screening and assessment tools. I think his first name is Dr. Bursa. I'm going to call him that because I don't know. But he said they often fall short of obtaining, regarding screen tools, he says they often fall short of obtaining additional information regarding social impairment, avoidance of specific activities due to BDD, the extent of which individuals engage in repeated behaviors due to BDD, and the duration of the disturbance. Results of a study validating a screening tool in particular settings may not apply to another environment. In addition, many tools have been not authenticated by psychiatric evaluation. This scholar and doctor recognizes that there's a lack and a gap of solidity for screening BDD, which relates to the concern of this thinking critically question. It's evident that BDD is often overlooked in the initial screening questions. Because BDD is a psychological disorder with physical impact, I often wonder if there could be a deeper collaboration between a doctor and psychologist professional to work with the intersection of the BDD causes. For example, in Tina's case, a doctor could recognize and assess Tina's physical wounds and perhaps give her a reinforcement that her behaviors are damaging and she should work with a therapist to get to the root of the disorder. Perhaps this could be done not only once as an initial screening visit for like a physical, but with a consistent checkups and with a doctor to increase Tina's motivation. I found this case of Tina to be extremely fascinating and informative. What surprised me most is I think that learning that there isn't a clear difference in the prevalence between rates of BDD between men and women, and it's so interesting how it manifests differently between the two. All in all, this was very eye-opening. It was fun to research, especially just with the stigma surrounding BDD. It was so great to get a little more understanding, a bit of a window surrounding it. So yeah, thank you guys.